The purpose of this next session is to introduce you to the bigger world of primary care practice-based research around the world, to give you a context of where we sit in this bigger picture. And I think we actually are pretty well positioned. We're going to be presenting something called Pearls from the North American Primary Care Research Group. I'm going to be co-presenting with my colleague, Dr. L.J. Fanyon, who is also a friend of Ren, a very good friend of Ren, and the director of a practice-based research network in Oregon. Dr. Fanyon is a primary care clinician who practiced in a rural community in Oregon, and now he directs the network of rural practices throughout Oregon. And I'm going to start the session, and Dr. Fanyon is going to take the second part. And so thank you for being here, LJ. I really appreciate it. NAPCRAG is a multidisciplinary research organization founded in the 70s. It's the world's largest primary care research group, and it presents a forum for new research all around the world. It's a binational organization governed by the US and Canada, but it's the go-to organization for researchers in Europe as well. Its goals are to promote primary care, nurture novice researchers, support PBRNs, and promote patient engagement, all of the goals that we share. LJ was instrumental in helping me form something called the Community Clinicians Advisory Group of NAPCRAG, which we created to maintain the clinician voice in the research community. The Community Clinician Advisory Group selects the most clinically relevant presentations at each annual meeting and puts them into a format called Pearls, and that's what we're going to present today. Each presentation is very brief. We're only going to hit the high points. There are 4 slides for each presentation. What's the question? What did the researchers do? What did they find? And why is this important for clinical practice? I have to apologize that there's a lot of jargon and acronyms on a lot of these slides, and I don't want to spend a lot of time explaining every single piece of jargon, which I think we're going to address with next year's Pearls, which were originally conceived for clinicians who sort of know what these things are. But for this audience, I just want you to see the big picture. Now, the first 2, I'm going to run quickly through 2 Pearls as one group to give a little bit of background to those of you who are not aware of clinical practice redesign. Patients in particular may not be aware that over the last decade, there's been lots of redesign of how healthcare is delivered in primary care. It's called the patient-centered medical home. It meaningful use. There's all sorts of things that are mandates to add to ongoing practice to hopefully achieve more efficiency and better health care. That's kind of the good, the bad, and the ugly. There's lots of burden placed on practices because of these mandates, but there are also some promising indications that maybe what we're doing is bearing some fruit. So the first Pearl has 2 parts. The first is PCMH, Patient-Centered Medical Home Implementation and Primary Care Provider and Staff Burnout. What's the relationship between this implementation process, which is basically changing in care processes and staffing levels, and burnout? And the relevance is that this is supposed to be a model for advanced primary care achieved through a team-based approach. Implementation is complex. It involves changes in care processes, staff roles, and staffing levels, and the implementation can directly impact provider and staff burnout. The researchers studied 2 practices in the New York area. I'm not going to go into details. One was a private practice of 90,000 patients. The other was a teaching practice of 52,000. And they surveyed the practices at 1 and 2 years after implementing the patient-centered medical home with measures to look at burnout, changing care processes, and staffing levels. there were many workflows created. They found many workflows were created, moving towards team-based care, and implementation involved planned increases in staffing in both sites. Site 1 achieved staffing and maintained it, the Site 2 didn't. What I found interesting is that these bars show that burnout increased in both sites, but it increased much more in Site 2. What does this mean for clinical practice? Any clinician in this room can probably attest to this, that the lack of improvement in burnout was probably due to many factors, but increasing responsibilities, workflows, and workload without a matched increase in staffing ratios probably played a key role in practice too. Many of us feel like we had to run faster on the treadmill just to stay in the same place. Second pearl, what about cost for the patient-centered medical home transformation? What's the cost and why is it important? There's lack of data on what's the burden on financial burden on practices for engaging in these mandates. So this was a literature review of all studies published in PubMed and other sources. And there are many different elements here's one of the acronyms. NCQA is the National Center for Quality Assurance. And they have 27 different elements that are supposed to be implemented. It's very complex. They boiled them down to 5 categories and then estimated that the cost to each practice for transforming those 5 elements was around $250,000. And what does this mean for clinical practice? It doesn't even include all the other elements, so the range is probably, it underestimates the total cost. So these results are helpful in determining the financial incentives needed for PCMH transformation. So these are just two of the challenges to many practices. Many of the people in this room who are in clinical practice are going through this process. So I believe I'd like to spend just a few minutes to see if anyone has any comments before I go on to the silver lining in the cloud. So I know some of you in this room I've talked to have had experiences with patient-centered medical home transformation and the increasing burden of clerical work and paperwork. So does anyone care to speak up on that, or shall I just keep going? But I think patients should be aware that this is going on and may impact their care. I see someone nodding there. So, yeah, Dennis.
John Baisley.
Okay.
That's me. I think, again, it illustrates the need to really both evaluate these changes in practice that are made, whatever they are, and do really scrupulous evaluation, and also to have them based on reasonably good science. What are the problems we're trying to solve here, and is there some evidence that the intervention will actually solve them?
Right. So this may be a topic for PBRN research, I think is what I'm hearing. Dennis?
This transformation, I think, has actually made it more difficult to do research, because we were talking last night about the role of medical assistants, and they just feel like they're just burdened to the max already. And even something that's pretty simple seems like an enormous additional task.
Okay, that's good information to know. How many more minutes do we have for this one? We're trying to keep on a schedule. I don't want to cut off conversation, but I also don't want to go over time for this one present. We're good? Okay. Anybody else have a?
One more.
Yeah.
Hi, I'm from Ministry Medical Group, and we are patient-centered medical homes. We're going through the accreditation process for the second time again. Patient-centered is a great way to do things. It's a very difficult mindset to bring throughout the clinic, but I think we're being impacted more as we're going to not fee-for-service, but quality-based kind of care, and that's adding a lot more checklists. Our referrals being done, and submit pieces of paper to insurance companies with checklists and all of those kinds of things. So people are really getting burnt out on what feels like checklist medicine. When we have to ask, are you continent now? And we have to ask this now. And the questions for rooming in they're getting more and more, and it's creating a lot of stress.
That's a very interesting comment. Tomorrow we're having a session devoted to quality indicators and what are we measuring the right quality indicators. You mentioned there's a lot of work being done. Do you think the quality indicators that we're being asked to do are the right ones?
Being driven by insurance companies.
What?
Many of them are being driven by insurance companies, and I'm not sure how those insurance companies came to those conclusions.
Okay. Good point. Have all these efforts paid off? It's good to know that there's actually a bit of evidence emerging that some of the care processes being instituted may actually be improving care. This is on the reduction in emergency department, that's ED, and hospital admissions from medical home practices is specific to primary care sensitive chronic conditions. The question was, are the outcome improvements for the PCMH, patient-centered medical home, specific to what the PCMH does? And then why is this important? We're doing, as I said, we're putting a lot of effort into transforming practices. Some studies find benefit, others not. If you see benefit, is it just because of better management overall, or is it actually because of all of this transformation? Okay, so what they did is they did a prospective study of a lot of practices in Michigan. This is a lot of patient practice years, over 5,000. And it's not really an intervention study. They actually observed the implementation of the patient-centered medical home, and they scored how much of it they were doing on a scale of 0 to 1, tried to adjust for what we call covariates or confounders. And then they measured things that are important, like hospital admissions, emergency room care, cost for various diseases, COPD, asthma, heart failure, diabetes, hypertension, and CAD. Those are exactly the conditions that we're going to be talking about in the rest of this meeting, versus all other conditions that the patient-centered medical home is not directly addressing. And so what they found was, I'm going to skip through this to the high points. They found that the emergency visits and hospitalizations decreased with increasing patient-centered medical home implementation score. So that's nice. The effect was 3 to 4 times as strong for the targeted conditions as for other conditions. And so that's also interesting. So what does this mean for clinical practice? Their interpretation was there was a general effect, a little bit, it was small, but a general effect of PCMH on improving cost and quality overall, but most of the effect was on the targeted conditions that the PCMH was designed to address, supporting the hypothesis that the medical home has the specific effect intended. And this was a very large sample in the wild of real practices, not just teaching practices or academic practices. So they were generally optimistic in their interpretation that there may be some value in all of this extra work. So toss it open for comments, questions. There's one here.
I'm Paul Hunter with the Milwaukee Health Department and Department of Family Medicine and Community Health.
Close.
I think it's really helpful to know that this actually does have some population health effect on what it's designed to, but I think that, and it's, I guess, encouraging to me that it might be worth the effort to try to make the logistics work and to prevent burnout and get over the hump of the implementation burnout issues. So I hope, that's easy for me to say because I'm not seeing patients every day. It's just a half day a month in a free clinic. So I hope that everybody who's doing the hard work every day of seeing patients can put up with the transition period so that the public health issues can really be addressed.
I know there are lots of folks in the room struggling with this and skeptical about is it all worth it. So I think there's still lots of work to be done, but it's good to know there are glimmers of hope here. Any other questions on this one? Okay, so I've talked about the good and the bad of implementation. I have one more to go, I believe, and then I'm going to turn it over to LJ. Now I wanted to talk about team-based care, which is part of the new healthcare delivery, and that's also a topic that could be on a research agenda. People are studying the effects of team-based care versus kind of the old way of doing things. This is clinical effectiveness of collaborative care management for depression over time. Depression is a common, significant condition for many people. So the question was, how much more quickly do depressed patients treated with collaborative care management improve when compared to usual care? And why is this important? There's previous work showing that the team-based approach, and they call it collaborative care management, is superior to usual care at 6 and 12 months of treatment. In other words, the team-based approach can be effective in improving depression over the scattershot previous approach. But it's not known how rapidly this happens. So patients care about how rapidly they get better, and they wanted to look at, did collaborative care management accelerate the improvement as well as sustain it. So this is called a retrospective cohort, where they looked backwards at a large data set of over 7,000 patients who were diagnosed. This was between 2008 2013, and taken from a primary care practice of over 100,000 patients. And they looked at patients who were enrolled in chronic care management by their physician or not. So this was not a randomized trial. And they looked at something called survival analysis, which says at what point did you achieve the desired benefit. And this was, they called it remission. There's a way of measuring that. And they also scored persistent depressive symptoms. Did they not achieve an improvement? And this is maybe, it's better, it's easier to see there. In both measures, the team-based approach improved the situation much more rapidly than usual care. The graph on the left is the time to remission. The dotted line was the team-based, and then the percent with persistent depression also was less. So both of those measures seem to respond to team-based care. So what this means for clinical practice is patients do care about how quickly they improve. The chronic care model showed improvement over usual care within the first month. The limitations are that this was not randomized, and then they talk a little bit about technical issues like survival analysis. So I think this is a shout out for team-based care in this particular condition. So I thought that was worth sharing. Any comments or, yeah, please, we've got to get you a mic.
I'm just curious if the team-based care meant that these patients came in contact with more social workers, more psychiatrists, more psychologists, was this held steady for the same number of visits? You know, possibly team-based care lets somebody with depression be talked to, you know, arm put around them, hand-holding, 6 or 7 visits versus maybe 1 or 2 doctor's visits. Were they controlled for the number of visits?
Yeah, I don't have all of those details, but the team-based approach generally involves a handoff from the clinician to a team of managers that could be clinical psychologists, social workers, nursing staff, all of whom can play a role, as you say, call it hand-holding, meaning frequent contacts to engage the patient, deal with issues, make sure that treatment courses that the patient has chosen in collaboration with the clinician are being implemented, whatever they are, whether it's cognitive therapy or medicines or whatever, yoga, who knows, so that these things are being managed over time. And that's really, I think, the crux of the difference between the old system I grew up in, where I made a diagnosis, I prescribed treatment, I asked patients to come back. Half of them did, half didn't. You know, that I think is really what we're talking about here.
Have you done a cost overlay with CCM treatment versus the prior treatment over a period of time?
Could you repeat that? I'm having a little difficulty hearing.
Have you done a cost overlay of the cost of providing a CCM treatment versus the traditional treatment over a period of time to determine, you know, whether the resources are being
Good
best
point.
utilized?
Is it cost effective? Will health systems be able to afford it? That was not included in this presentation, which, by the way, was from Great Britain, so they have a completely different structure for doing cost-benefit analyses. I think that's a big issue. Will health systems devote the resources needed to do team-based care? I think that's up in the air. I think that's ripe for a research agenda. And I'm not a content expert in that area. I don't know if you have any knowledge. But I think that's a huge issue. The U.S. Preventive Services actually baked in a B-level recommendation for depression screening and management on the basis of practice-based research in practices like mine. I was actually involved in one of the early pilot studies. But the caveat was, they only recommend it if the systems are in place to do the chronic care follow-up, and not everybody has that. Okay, I'm going to turn the podium over to Dr. Fanyan to...
So do we need that, or?
you can have, yeah, let me give you this one, and then you can...
Get rid of that. So great. It's wonderful to be here in Wisconsin. I really am surprised at the number of folks that are here. I've had a chance to be here before, and I want to just reflect on it. But before I do that, I want to get an idea of who's here. How many of you are patients? Would you raise your hand? Everybody should raise their hand if they're patient, but I, here in the patient role, so that's helpful. How many of you are clinicians who make your living seeing patients? That's impressive, because that's how you make your living, and it's Thursday, and unless it's your day off, you're investing in this conference. That's quite impressive, and I think, David, you showed that there are 135, 140 folks that are here. I've had a chance over the years. I'm in Oregon. I'm a family doc. I have a bimodal career. Half my career was with the Indian Health Service in a small rural practice on the Oregon coast. The other half's been at an academic health center. And so in the academic health center side, I've been involved in practice-based research, and we have a PBRN called ORPRN, the Oregon Rural Practice-Based Research Network, and I've had a chance to come out to Wisconsin and get to know REN quite well. Known Dr. Beasley, Dr. Tempte, Dr. Smith, and now Dr. Hahn. I may have missed some of the leaders of REN over the years, but REN is revered as one of the original PBRNs. I got to come here in 2006 when they wanted to reboot, and there were like 20 folks that were sitting around here, and they were all clinicians trying to figure out what's the next phase of our network. And this conference is beginning to tell me that you're well on your way to continuing to make a difference. The other time I got to come was to a faculty meeting that was, I think it was at Wisconsin Dells, and John Tempte invited me to come and participate in discussing primary care. but at the faculty business meeting, he gave me the option of borrowing his Prius and knowing that I'm a bird watcher to go to the International Crane Foundation and in Baraboo, and I took advantage of that. And I'm sure I missed a great faculty business meeting, but I really had a good time because I got to see a pair of cranes of all the different species of cranes around the world. That was really impressive. And now here to participate in a convocation that has got patients as well as clinicians. And just a little bit about these pearls. We'd really like to have you weigh in, because this comes from the evaluation of the clinician advisory group of NAPCRAG, people that make their living seeing a patient, saying these were the things that really caught our attention that were meaningful to practice. So as you respond, we'd like to have you think about what are the research questions around these presentations that we need to explore around these particular topics. So please weigh in on that. Also, are there things did we get it right in selecting this? Is this truly relevant to your practice? And I think this first one we're going to talk about is shared decision making. How many of you know about shared decision making? Raise your hand if that's really pretty impressive, because I bet you 5 years ago there wouldn't have been many hands raised about shared decision making. I think most of the clinicians feel, it's kind of what I do. And the answer is it's really not what you do when we really study it, and we can talk about that in more detail. But this is shared decision making in palliative care, looking at how do patients and healthcare providers construct patient participation in palliative care decisions. And this is through a discourse in community hospital-based palliative care teams. This seemed like an important topic. And how many of you find this challenging? Yeah, I think, it's a really tough thing to do. And I'm not sure we've got a really good structure for this. There's a lot of uncertainty. I'm really lousy at predicting what my patients want to have happen. If I just, without asking them and having a conversation, I miss it half the time. And so this is kind of designed to figure out how to have that conversation early on. And the role that we play as family physicians in end-of-life issues is huge. We shouldn't abdicate that to hospitalists. We need to be there at the most vulnerable points in our patients' lives. And so I think this question is very important to us. So this is an ethnographic and discursive psychology study. Fancy words, aren't they? Where they just kind of observe what happens and tries to look at the culture of the settings that these conversations are taking place. And they involve patients, palliative care team, and field notes, where they just kind of wrote down what they found, and also audio recordings analyzing the consultations, and field journals. And they were wanting to look at these conversations in that context, and how did patient participation happen in those conversations. And they found things that I don't think are surprising, but I'd like to hear from you, is that early referral and discussions ensured the patient opportunities to participate in decisions. These are palliative care teams, and so oftentimes, we go into things with a fair amount of hope, and then things sometimes change. But we need to initiate the discussions early on here, and so they talked about patients retaining control on whether to discuss end-of-life issues. How do you identify when patients are ready to have that conversation? Patient participation was facilitated by exposing uncertainty, trying to get at treatment preferences and values. I think oftentimes we don't know what patients' values are, and affirming patient autonomy. This is your decision, and resisting the patient's attempts to uphold our clinician authority. where patients say, well, why don't you tell me what to do? I imagine that happens to you, tell me what you think's best for me. And, it's our obligation to say, I'm really not you. I need to know a little bit more about you, and this is your decision. So what does this mean for clinical practice? How do you introduce decisions early and talk in a way that promotes participation? Any thoughts about that? I'm going to just kind of stop right there and see if somebody wants to comment about that. How do you introduce the decision? How are you doing it now? And how do you get your patients to participate in the discussion? You guys are pretty wise, so I'm hoping for some feedback back to our clinician advisory group about what the Wisconsin folks told us. Anybody want to step up to the table? I'm going to be here for a bit.
Well, often, Andy Wright from Richland Center, often the conversation doesn't happen. Right now, I think that's most common, but there is an initiative in our state with honoring choices, which we have signed on to as a clinic and as a hospital, and I think that's really going to help. So if you ask us in a year or year and a half, probably we'll be having a lot more of these conversations.
And that's called honoring choices?
Yeah, it's based out of a psychologist at Gunderson Lutheran in La Crosse, who really had Respecting Choices was his program. And so the La Crosse area has a 98% advancce directive in place. It's
I actually read about. Yeah, that's pretty impressive. And do you have pulse forms here? Is that the La Crosse? Is it across the state then? That's the physician orders for life-sustaining treatment, because it's different than advanced directives and living will, and and I'm kind of partial to that because Susan Toll is the director of our health care ethics program, and Susan's been. We've actually promoted that in our network a lot because physicians don't know how to use a pulse form or when to use a pulse form. I don't know, maybe you folks know here in Wisconsin is, when does a pulse used, when is the advanced directive or living will fit in. So we're learning about it, and so we need to continue to have that conversation. And that gets to the last point here about we need to have a better understanding of clinical communication guidelines, and we need to reflect on arguments that can achieve patient participation. And I'm not sure we know what the scripts are yet for optimizing that. And any other thoughts about this, these findings here, and how to stimulate the conversation? Oh, good.
I'm a patient, and I'm in Minneapolis, and I didn't know that doctors were talking about end-of-life options. And at my last appointment, she gave me a booklet. She said, do you have a end-of-life, whatever it's called? And I said, oh yeah, I had one a long time ago. And so she hands me a booklet and says, fill it out and bring it back. Well, I thought, this is really boring. Why would I want to do this? I mean, I want to live. I don't want to talk about dying. I want to talk about living. And while you're talking here, I thought, well, how would she have been able to get me to look at that? Well, if there was a person that she could refer me to, either then or at another point, so we could talk about these things in a comfortable setting, I maybe would have talked about it. Now it's just sitting on a pile of junk that I'm putting, to go to the garbage, or to recycling, that's right. So I think there needs to be, if you're going to talk about it, you need somebody to talk about it with. You're not going to go home and talk to your kids. Right. Your kids are saying, what are you talking about dying? I don't want to hear about that. And so I think there just needs to be more the patient engagement by having a person available to you to talk about the questions and to help you think about them, because they are not the kinds of things that are fun to think about. It's fun to think about what next play I'm going to go to, and what next dance I'm going to go to, and what next friends I'm going to see, and where I'm going to go for happy hour. Those are fun things to talk about. But who wants to talk about dying? So that's my idea, okay?
No, that's a, boy, what powerful comments, because that's, you know, so I'm like your doctor. I tend to do the same thing your doctor does. I haven't figured out how to do this and to figure out a good approach to do it. I think you're right on target. When to introduce it, how to introduce it, what's the appropriate team member to participate. And so we've actually been, you know, YouTube's a pretty powerful thing these days, and so we've put the Pulse discussion on YouTube, and people can watch it kind of at their leisure, and you know, and come back. It takes time. We haven't figured out the workflow around this.
In the
Paul?
acute care setting, in the acute care setting, I've seen physicians successfully introduce the conversation moving towards palliative care when there's still hope to be successful in recovery, so that, you know, the conversation will go something like, you know, I know when I'm looking at this that, you know, we could have a grave outcome, but at this point in time we are still working on this and this and this and this. So when there is still an option for care that is still in front of them, they point that out, but that if those things aren't successful, something else will happen. So then at least the seed is planted and the family begins to do some of their own thinking and prep in making some of those decisions.
That's a great way of looking at it, because we're not talking about excluding treatment or just saying, you know, we're, you know, going in a different direction. And you had a question here.
Yeah, I'm a researcher of patient perspective, so I interview patients. And what I've heard more important than anything else is for people to be able to say, these are the things that are important to me, these are the things that I want to be able to continue doing, which is a theme that was mentioned earlier. And so it seems to me, in order to begin that conversation about the palliative stuff, what you really have to understand is more about what that person's agenda is right now for talking with you, and they shape the agenda. They may not want to talk about the palliative stuff, but more than anything else, to prepare for that conversation is to understand their values in terms of what they value in their life. What will make it worth continue living? You know, is it the trip to Disneyland with the kid? Is it the, you know, whatever?
I like that trip to Disneyland. You know, it's like I want to go hunting with the guys again next year. You know, might be it. Paul?
Can you hear me? These conversations about shared decision-making between clinicians and patients can take a lot of time. They also occur within a cultural context with preconceived ideas that people come into that from both sides. And I'm thinking the way I now work for the past several years as a public health practitioner is I look at that and I say, why don't we work on the stuff outside of that by doing education? And the example right now is the HPV issue, vaccination issue, where there are grants in the state of Wisconsin, which I think are having an effect based on a conversation I had with a pediatrician recently, that are going both towards educating clinicians about how to approach that conversation, and public, you know, that this is about cancer, not about sex. So to change the frame of reference to the conversations. And I'm just wondering if you could comment on that, and what the role of clinicians and patients is in elevating it out, or not elevating it, but just taking it out of that interpersonal conversation to more of a public discussion.
Yeah, that, you know, I'm not sure, you know, how best to kind of get this out there. We've actually done some group visits, used a group visit model to use decision aids around end-of-life care, and that seems to be another mechanism for moving it maybe out of the exam room into the bigger population of patients. Yeah, just one last word about shared decision making. The one mantra I like with shared decision making I want you to remember, it comes from the British, who think a lot about this, is no care about me without me. So remember that. No care about me without me. And that goes for a lot of these discussions. So we're going to talk about continuity of care. That's kind of one of the core values of primary care, is continuity. And does having the same primary care provider over time predict patient-reported experiences of care and patient-reported impacts of primary care? So I'm going to have you answer the question. I'm not going to tell you, go through why this is important, and I'll tell you what they found. But unfortunately, I think you've got the slides in your book, but that's okay. So I want to ask you this. Does high continuity of care predict patient-reported experiences of care? Somebody want to comment about that? It's a good thing to have continuity? So where are you going to get the evidence that that patients want that?
We're going to see the next slide.
Okay, we are going to see the next slide. Any other thoughts about it? I mean, you know, yeah, Paul, we got, go ahead.
With the risk of sounding a little bit jaded, I think that continuity matters a lot more to clinicians than it does to patients.
You know, I don't think that's jaded at all. I mean, it's a complex world out there. We're going to get another comment here, but you know, I do, as a physician, value that continuity a lot, and so I wonder that too. If I'm, if it's more important to me than it is to my patient. But I kind of deluded myself into thinking that it's important to the patient. Yes.
I'm a patient. Okay, that's my only interaction with the medical field, and I will have to disagree with your statement. Continuity is important to me, that I have somebody to go to talk to, and I have informational sources to utilize. That's what I refer to as continuity of care.
Thank you, Joe. Yes.
Yes, hi. I'm an internal medicine physician, and I'm one of the few left who also do outpatient and inpatient, so I do see my own patients in the hospital. And I cannot stress enough how important it is for the patient and myself both. And a lot of times, I don't want to name the hospital systems, but our patients do get stolen by the hospitalists. Always there's this miscommunication. And it's just, it's bad for the patients. They come over and, doctor, I was in the hospital, how come you didn't come see me? Because I can see the joy on their faces when I go to see them in the hospital. They feel like, oh, there is somebody who knows me. Because sitting, laying down in bed in the hospital gown, they look entirely different as compared to what I have seen in the hospital. And when a lot of times when I tell the nurses, okay, you know, this patient, until about 5 days ago, she was driving and she was a normal person, they are really surprised because they all look the same, they look different, and people who see them in the hospital they have a different perception of their personality. So I think that's very important.
Well, I want to honor what you're doing there. I think that's really impressive to have to go through, and not only in the office, but to take care of your patients in the hospital. And thank you for sharing that inspiring message.
Also, financially, it's not at all feasible, but that makes my day because, you know, it can take up to 2 hours just for one hospital trip and get paid for maybe 10 minutes. But I think it's very important for the patient and myself, and it gives you, you know, a lot of, it's very rewarding for both.
One more comment and then.
Okay, well, I've been in healthcare for almost 30 years, in primary care for 20 as a nurse practitioner. And our experience in our clinic, if it reflects the population around here, patients are fiercely loyal. They will wait weeks to get an appointment if that's what it takes. They don't want to explain to somebody else all their problems, even a new one. They want somebody that they know, and it even goes to a phone call and a message. So our experience is it's extremely important that they have the one-to-one or at least the small team experience rather than shared amongst 15 different people. We tried that, and we went back to what it was.
Right. So I'm going to move on to the results here, but you know, our role, I got 2 minutes, so the role that we have in primary care is to be sense makers. out of all the complexity that's out there with us. And the other thing for me, and I think Paul mentioned it, is I value my relationship with the patients perhaps more than the patient values it with me. But actually, I like my patients to know them as people. I like to know them beyond heart disease, beyond diabetes. I like to know who their families are, who their kids are, where are they going on vacation next summer. And that's just me. I'm into the relationship as much as I am into the medical aspects of that. But not everybody's that way. So they did random digit survey, linked the survey to administrative data, and here's what they found. And they looked at continuity of care associated with older age, chronic conditions, higher score on aggregated diagnostic groups. So they're looking at severity, together, and female gender. And continuity of care predicted our knowledge of the patient. It seemed to enhance shared decision-making, and there was increased confidence and satisfaction. But interestingly, it was not predictive for interpersonal processes of care or patient activation. That by seeing the same clinician on a repetitive basis, it didn't increase the patient activation measure. Surprises or comments about that? Okay, I think. What's this mean? This says higher continuity care is important for influencing some experience, confidence that people can obtain and use care when needed, appropriate use, knowing that you're going to be there. I think there's a lot of value in that. I know I'm supposed to talk about this, but I have a colleague, Bill Phillips, who I value a lot. And Bill told me one time, and I think maybe Valerie and others of you have heard this. Bill said, you can pretend to know, you can pretend to care, but you can't pretend to be there. And I think that's our value as family physicians and primary care physicians, that we're there. And I actually do think patients value that. Maybe we just haven't got the right study up there yet. Do I get to do the last one? Okay. So I want opinions about this. We're going to ask for a raise of hands and see. We're going to go straight to the answer here. Does an increase in opioid dose lead to an increase in depression? All those who think it does, raise your hand. Okay. All those, I'm just assuming the rest of you, think it doesn't or not sure here, but that's an issue. These were patients with chronic low back pain, and we always have that question of, if I increase the opioid dose, is that, I may need to do that because there is some tolerance to opioids, and we often think that we need to increase the dose because they've built up some tolerance to it. But are we putting patients at risk for depression by increasing that? And so this was a study looking at that, and they were looking at the morphine equivalent dose with patients with chronic low back pain. And so this was non-cancer patients. This was done in Sandra Berg's practice-based research network. I think it's in San Antonio or down in Texas there. And looking at prospective cohort study, pretty cool design, and looking at data from chart abstraction and screening for depression using PHQ-2. And they found, compared to no use, increasing opioid dose was associated with more than a twofold increase in the probability of depression over time. Twice as much. And an increase to 1 to 50 meds was not significantly associated with increased probability of depression. So it was the higher dose, the greater than 50 med per day dose. And what does this mean for practice is that we should consider when examining the dose of opioids being used when chronic pain patients report depression and discuss the risks for increasing the dose, I guess another opportunity for shared decision making about what do we do next. And that needs to be shared with patients, that that's one of the adverse effects of going up on your dose of OxyContin or whatever you've got the patient on. And that routine screening for depression among opioids using patients may detect depression at an earlier stage. And I don't know how many of you are screening for depression with your opioid users as a specific population. Anybody doing that? Tell me how you arrived at deciding to do that.
In fact, we do the PHQ-9 testing on all of our patients, whether it's chronic pain or not, so they just get it done routinely.
So it's universal screening?
For all of our patients.
Got it. Got it. Yes.
And every visit there's a questionnaire, and there's the questionnaire about how you're doing, and then it leads into more questions leading towards the depression. So, and the provider always looks at that and questions it if there's anything leading to that. And that's at every visit for me.
So how does that feel to you as a patient?
I'm glad they're looking out for me.
What's it? Yeah?
Yeah, I'm glad they're looking out for me.
Wonderful. Wonderful. Thanks.
I know it's not the point you're trying to make about shared decision making, but I question whether the increasing opioid dose just meant that their underlying disease was getting worse and therefore they were more depressed.
Yeah, that's, that gets to be a bit of a confounder there in trying to untangle that. But I think that, they've tried to kind of look at that variable and have been able to kind of think that increasing the dose of medication is really relates to the depression. And I'm not quite sure how they would say, you're getting worse osteoarthritis of your spine, your spinal stenosis is increasing, and that's the reason for that. Yes?
I mean, chronic pain is depressing in itself, and
yeah.
I've seen this over and over again, patients with chronic back pain and spine pain, and if they were having cancer or chronic headaches or something like that, that's quite depressing in itself. So I don't know how you'd separate out the opioids.
I think it's got to be really challenging. Again, a part of the discussion process about, here's what some of the evidence shows, and to have a discussion about that. I think there are a lot of folks, a lot of us that think that opioids are overused, and that we've not been looking at non-pharmacologic modalities for addressing chronic pain in these populations, and so there may be some other alternatives we want to be talking about patients rather than increasing their opioid dose, and so it may influence the conversation that way. So I've got any other comments? So I'm going to, any other closing comments about the NAPCRAG pearls? Are there any research studies that are coming out of this you want us to focus on and take back, that we should really study this? Anything come to mind for you that you don't know about that you'd like to see studied?
I think it'd be really interesting to see whether clinicians actually believe research. Because a couple of these studies, there was evidence, and the response to it was, well, I guess that study didn't show it, but maybe we'll find another one that shows there's evidence for what we already believe. And how much do people actually look at research to change what they believe, or just believe what they believe, and then read a study and say, well, I guess that doesn't support it, but how much evidence does it take to affect people's beliefs?
That's a great question. What dose of information and evidence does it take to change? Because I'm unlikely to change right away with one new piece of evidence, but if I see a cumulative amount of evidence, I'm thinking, I probably ought to quit doing what I'm doing here, or make some changes. But I don't know any researcher that's around it. But that's a great comment. We're going to record that, I hope, and take that back. Any other research questions?
I could say 3 words: global climate change, and how that may operate. But I think my question would be patient literacy as far as healthcare, and that depending on the patient being treated, how these studies are done and how these questions are asked can be very different for a lot of different reasons. And even though we may have some controls on that, the answers you get may be not valid in other circumstances, be it socioeconomic, cultural, or whatever. And so far, we've not really heard about a lot of those glosses that may be affecting the studies that you're doing. And when you're talking about patient-centric care and patient involved in the decision-making,